Now we're going to start talking about the adrenergic blocking drugs, which are going to do just the opposite of the drugs that we just learned about. Okay, so what these drugs do is they bind to those adrenergic receptors, but by doing that, they actually block the stimulation of the sympathetic nervous system. So even though they're binding to the same receptors as the other medications we just learned about, just like epinephrine, but instead of creating a response, they block the response of those catecholamines that we learned about. So they have the opposite effect of adrenergic drugs. They inhibit or lyse sympathetic stimulation. And that's why sometimes we call them sympatholytics. Okay. Okay, and this is what we just talked about. These are adrenergic antagonists, so they're against the adrenergic response. Sympatholytics is another name. We have the alpha blockers, the beta blockers, and the alpha beta blockers. So, we have those alpha 1, alpha 2 receptors, the beta 1, beta 2 receptors. So, it depends on what they block as to what kind of effects they have on the body. So, they are, again, classified by the type of adrenergic receptor that they block, whether it's alpha 1, alpha 2, beta 1, or beta 2. So these drugs, the alpha blocker drugs, cause both arterial and venous dilation. And when you have that kind of dilation, it causes a decrease in blood pressure because you have decreased vascular resistance. So these drugs are used to treat hypertension, and some of these drugs treat BPH because there are those type receptors also on the prostate gland. And the bladder decreases resistance to urinary outflow, thus reducing urinary obstruction and relieving those effects of BPH. So what are we going to use alpha blockers for? We're going to use it to prevent hypertension, especially in patients with pheochromocytoma. We're going to use it for Raynaud's disease. You can see how, Raynaud's is those vessels constrict to cause that bluish color in the hands or the toes. And so you can see how something that opens up the vessels would be good to treat Raynaud's, acrocyanosis, and frostbite, just to increase that blood flow to those areas. Phentolamine is a drug that you actually inject, I think we've talked about this a little bit, into the area where those drugs we talked about in the last few videos, extravasated vasopressors. So they leak out into the tissue, extravasation, and you inject this around that area, the phentolamine around that area, to reverse the effects of those clamped down vessels in the tissue there, so that it restores blood flow and prevents that tissue necrosis from lack of blood flow to the area. When phentolamine is used to diagnose the presence of pheochromocytoma, the nurse will assess for what indicative finding. So if you give phentolamine as a drug and you're trying to see if they have pheochromocytoma, what's going to happen? What do you expect to happen? Rapid decrease in blood pressure, a steady increase in blood pressure, a slow heart rate, or reduced cardiac ectopy. So what is the problem with pheochromocytoma? increased blood pressure. So if we give phentolamine and they have a rapid decrease in blood pressure, that would indicate that maybe they do have pheochromocytoma. So A is the answer. To help establish the diagnosis of pheochromocytoma, a single IV dose of phentolamine is given to the hypertensive patient who may have that tumor. If the blood pressure declines rapidly, it's highly likely that the patient does have pheochromocytoma. All right, so let's look at the adverse effects of alpha blockers. Cardiovascularly, you may have some palpitations, orthostatic hypotension, tachycardia, edema, and chest pain. For the central nervous system, dizziness, headache, anxiety, depression, weakness, numbness, and fatigue. So why do we have those type of effects? Well, especially with the first dose of these alpha blockers, you can have what's called first dose phenomenon, which is a severe and sudden drop in blood pressure after administration of the first dose. So we have to make sure and educate our patients on that they might fall out. And that's, having a decrease in blood pressure is actually one of the things that we want alpha blockers to do, but we have to be careful about overcorrection. So palpitations, that's just your heart trying to respond to that decrease in blood pressure. So it's increasing the contractility of the heart and also causing tachycardia because the medication, the alpha blocker, is causing hypotension. So what does the body try to do to fix the hypotension? Because we need our cardiac output up, it tries to increase the contractility of the heart and the frequency with which the heart is beating, so tachycardia. Because these medications decrease blood pressure, you can have orthostatic hypotension, so we need to be teaching about changing position slowly. You can have some edema. Well, why would that be? Think about dilating the blood vessels. When you relax that blood vessel, it becomes a little more leaky than if it was tightly constricted, right? So you're going to have leakage of fluid out into the tissue and edema. Okay, central nervous system, the dizziness, headaches, anxiety, depression, weakness, and numbness and fatigue. Gastrointestinal, you may have some nausea and vomiting, maybe even some diarrhea, constipation, and abdominal pain. So incontinence can happen as well. Think about why we give that BPH medication. It kind of relaxes the neck of the bladder. You can also have dry mouth and pharyngitis. So when administering an alpha blocker for the first time, it's important for the nurse to assess the patient for the development of what adverse effect? Renal failure, hypotension, blood dyscrasia, or dysrhythmias? What do you think it is? It's B, hypotension. The primary adverse effect of alpha blockers are those related to their effects on vasculature. So you get that first dose phenomenon, like what we were talking about, and you can have a severe and sudden drop in blood pressure after that first dose. Everybody that has this kind of medication should be warned about this adverse effect before they take that first dose of an alpha blocker. Orthostatic hypotension can occur with any dose of an alpha blocker, so we have to teach them to get up slowly from a supine position. Okay, what makes these drugs to where you don't want to give them to the patient? Any kind of known drug allergy, peripheral vascular disease, hepatic renal disease, coronary artery disease, peptic ulcers, or sepsis. All right, here are just kind of a list of some of the common alpha blockers. Phenoxybenzamide, phentolamine, prazosin, terazosin, alfuzosin, tamsulosin, and doxazosin. Okay. All right, so phentolamine, Regatine, we've talked about that a little bit. This alpha blocker reduces peripheral vascular resistance and is also used to treat hypertension, especially in pheochromocytoma. But its most common use is to treat extravasation, and that's in those vasoconstricting drugs that leak out into the tissue when you have an IV go bad. So norepinephrine, epinephrine, and dopamine. It's contraindicated in known hypersensitivity, in myocardial infarction, and coronary artery disease. Flomax. This is also an alpha blocker, and it's used primarily to treat BPH. It's exclusively indicated for male patients. However, it can be used in females with kidney stones. And I will also say that my doctor tried me on this once when I had some problems with constricture in the urethra. It didn't really help me too much, but there are some female patients that it does help because it relaxes the neck of the bladder. So known drug allergies, don't use it if you're allergic. Don't give it to your patients if they're allergic. If they have erectile dysfunction and they're taking sildenafil for that, you want to not give them Flomax at the same time. Okay, so adverse effects, they can have a headache, abnormal ejaculation, rhinitis, and there are other adverse effects too. Beta blockers. We hear a lot about beta blockers, OLOL drugs, right? This blocks the stimulation of the beta receptors in the sympathetic nervous system, and what it does is it competes with norepinephrine and epinephrine, and it can actually knock norepinephrine and epinephrine off of the receptor site so that it can block it. It can be selective or non-selective, the drugs can. Cardioselective beta blockers are beta-1 blocking drugs. Remember, we have one heart, so beta-1 is for heart. Non-selective beta blockers block both beta-1 and beta-2 receptors. And remember that beta-2 receptors are mostly located primarily in the smooth muscle of the bronchioles and blood vessels. So if we block those receptors, we're going to have bronchoconstriction with these drugs. A few of the drugs that are out there not only block beta adrenergic receptors, but they also partially stimulate them. And these are the acebutolol, penbutalol, and pendolol. Okay? So carvedilol and labetalol are alpha receptor blocking activity, especially at higher doses. So they are beta blockers, but they actually do some alpha receptor blocking activity as well at higher doses. Okay, so the beta-1 receptors are primarily located in the heart. Beta blockers selective for these receptors are called cardioselective beta blockers. Okay, beta-2 receptors primarily located in the lungs, the bronchioles, and blood vessels. So how do they work? Cardioselective beta blockers reduce sympathetic nervous system stimulation of the heart. So they decrease the heart rate, and the way they do this is to prolong sinoatrial node recovery. They also slow conduction rate through the AV node of the heart. They also decrease myocardial contractility, thus decreasing the myocardial oxygen demand. So if you have someone with some chronic chest pain due to myocardial oxygen demand not being met, this might be a good class of drugs for them. So the non-selective beta blockers, which are beta 1 and beta 2, cause effects on the heart just like the cardioselective beta blockers, but they also constrict the bronchioles, resulting in narrowing of the airways and shortness of breath. Okay, they produce vasoconstriction of blood vessels, and this is how that shortness of breath comes about. Constricts the bronchioles and the vessels. Okay, so why do we give beta blockers? For angina, so that we can decrease the demand for myocardial oxygen. That's what causes pain. Remember, we talked about any muscle that is deprived of oxygen or has decreased oxygen will hurt. So that's what happens in angina. They are cardioprotective drugs. It inhibits the stimulation from circulating catecholamines. So if there are epinephrine, norepinephrine circulating around, these beta blockers block that stimulation. So these are used in patients who have had an MI to block those catecholamines, to kind of let that heart muscle soothe down and relax for a little while. We use it in dysrhythmias. These are considered class 2 antidysrhythmic drugs, and also migraine headaches. And because these type medicines really like fat, it allows them to enter into the central nervous system. All right, so they're used a lot of times for antihypertensives because they have an ability to reduce the sympathetic nervous system stimulation of the heart, and that decreases the heart rate and the force of the myocardial contractility. So they're used in heart failure and also in glaucoma for topical use. So that's the timolol drops that we give our patients. All right, we have a 58-year-old patient who's recovering in the intensive care unit after a myocardial infarction. The nurse notes an order for the beta blocker metoprolol. What is the purpose of this drug? So we've got a 58-year-old that just had an MI. What is the purpose of this drug? To dilate the coronary arteries, to inhibit stimulation of the myocardium by circulating catecholamines, provide a positive inotropic effect, or maintain the patient's blood pressure. B. Studies have shown an increased survival in patients given metoprolol after experiencing an MI. It has a cardioprotective effect by decreasing the heart's response to those circulating catecholamines resulting from the MI. So the norepinephrine, epinephrine. Okay, so why would we not give beta blockers? Well, if they have an allergy, of course. Uncompensated heart failure, cardiogenic shock, heart block, bradycardia, because we don't want to make that worse, right? We don't want to give it in pregnancy. Severe pulmonary disease, because it can cause bronchoconstrictions, and Raynaud's disease. Okay, so here are some adverse effects that you can get from beta blockers. Agranulocytosis, thrombocytopenia, cardiovascular effects. You can get an AV block, bradycardia, and heart failure, central nervous system, dizziness, depression, unusual dreams, and drowsiness. Gastrointestinal, nausea, vomiting, diarrhea, and constipation. And these medications can also cause impotence, alopecia, wheezing, bronchospasms, and dry mouth. So non-selective beta blockers may interfere with your normal response to hypoglycemia. So we have to be really careful in diabetics who are prone to hypoglycemia because some of the side effects that kind of cue you that the patient is having a hypoglycemic episode are hidden with these drugs, like the tremor, the tachycardia, and the nervousness. So it can mask those signs and symptoms, and we have to be really careful in our patients with diabetes. So toxicity, if they take too much or overdose on beta blockers, we need to do some symptomatic and supportive care. You might want to give atropine for bradycardia. Be ready to pace the patient because these blockers will slow that heart rate till it's non-existent or too low to be functional for the patient. So be ready to do cardiac pacing. Might want to have to start some vasopressors for hypotension. And just something to keep in mind, dialysis does eliminate these drugs from the blood. So that could be very helpful if you have an in-house dialysis unit that could come up and dialyze the patient to try to get rid of these beta blockers. So what do they interact with? Anything that might have an additive effect. So some drugs that have similar mechanism of action. So you want to be careful about giving them with drugs that might have the same effect. And remember about the hypoglycemia, that the beta blockers can mask the tremors, the tachycardia, and such. Atenolol. This is a cardioselective beta blocker, and it's commonly used to prevent future heart attacks in patients who have had one. It's used for hypertension and angina and management of thyrotoxicosis to help block the symptoms of the excessive thyroid activity. So what are some of those symptoms for excessive thyroid activity that a cardioselective beta blocker might block? It would be things like tachycardia, right? It's an oral drug. Carvedilol or Coreg is very commonly used. It's non-selective beta blocker. It's also an alpha-1 blocker and a calcium channel blocker, and possibly an antioxidant. It's used in heart failure, hypertension, and angina. And the way it's used in heart failure is kind of slows the progression of the heart failure and decreases the frequency that the patients are in the hospital. It's most commonly added to digoxin, furosemide, and an ACE inhibitor when it's used to treat heart failure. So it's not used just on its own, but in addition to dig, furosemide, and an ACE inhibitor. Esmolol is a really short-acting but super strong beta-1 blocker. And when we use it is in really acute situations to provide rapid but temporary control of the ventricular rate in patients with supraventricular tachydysrhythmias. Okay? And it's given IV, of course. So the nurse knows that the adverse effects of non-selective beta blockers are likely to be the most immediately life-threatening in which patient? Patient with type 1 diabetes, patient with asthma, a patient with gastroesophageal reflux disease, or a patient with hypertension. B. Although the beta blockers may mask signs and symptoms of hypoglycemia, the non-selective beta blockers can cause bronchoconstriction, which could be life-threatening to the patient with asthma. Okay, so definitely something to keep in mind there for the beta blockers and asthmatics. Metoprolol. It's the most commonly used beta-1 blocker. It comes in oral and injectable, and whenever you give it IV, you should have the patient on a monitor and give it at the rate that you should and not any faster, because it can drop your heart rate out. And remember that metoprolol, although it is used for blood pressure, has more effect on the heart rate than anything, but it does help blood pressure as well. Usually, though, you'll see people who have both heart rate and blood pressure issues are given metoprolol. Propranolol. This is a non-selective beta-1 and beta-2 blocking drug, and it's used for tachydysrhythmias, subaortic stenosis, migraine headaches, and essential tremors. It comes in oral and injectable forms. Sotalol, or beta-pace, is a non-selective beta blocker as well. It's a really potent antidysrhythmic, and it's usually given for difficult to treat dysrhythmias, and it's just oral use. Here's a list of some non-selective beta blockers, some of them that we've gone over already. That timolol at the bottom, that's your optic solution that you use in the eyes. Here are the cardioselective beta blockers. Acebutolol, see the OLOL on the end of them? Don't forget about that. Atenolol, betaxolol, esmolol, nebivolol, and metoprolol. Okay, so the indications of these adrenergic blocking drugs. We always have to assess for allergies and any problems with the breathing, a history of COPD or asthma, because giving these medications, some patients with these diagnoses are given the medications, but you need to be aware that it could cause bronchospasms in these patients. You need to know that it causes hypotension, and so we'll need to assess them for a history of that, because it could be dangerous for someone to be given a beta blocker who already has a hypotensive problem. Cardiac dysrhythmias we need to assess for, bradycardia, heart failure, and other cardiovascular problems. Any pre-existing condition that might be exacerbated by the use of these drugs might be a contraindication to their use. So these are type things that we need to bring to the attention of the physician, and there may be a reason that they would want to go ahead and give it, but definitely they need to know about it. So once again, remember that alpha blockers may precipitate hypotension. Some beta blockers may precipitate bradycardia, hypotension, heart block, heart failure, and bronchoconstriction. We want to make sure that we tell them to avoid over-the-counter medications because of possible interactions. And here are a few interactions that can cause a problem. Antacids will cause you not to be able to absorb the medication as well. Antimuscarinics or anticholinergics, diuretics and cardiovascular drugs, neuromuscular blocking drugs, and oral hypoglycemic drugs. So remember those interactions that may occur with those adrenergic blocking drugs. Encourage your patients to take their medication as prescribed and remind them to not stop abruptly. They need to report to you any constipation or development of urinary hesitancy or bladder distension to make sure that those are not some side effects from some of the medications. But they should not abruptly stop the medications anyway. You just need to know about it so that you can help them either wean off the medications according to what the doctor prescribes, or treat those problems in another way. We're going to teach them to avoid postural hypotension by changing positions slowly. Have them avoid caffeine to avoid excessive irritability. Instruct them to avoid alcohol because especially when they're first starting to take the medication, because it can potentiate the problems of orthostatic hypotension, those kinds of problems. Tell them to notify their physician if they have palpitations, shortness of breath, nausea, or vomiting. Of course, you want to monitor for any adverse effects, but also monitor for the therapeutic effects. Are they seeing a decreased amount of chest pain? Is their blood pressure and heart rate returning to normal? So just whatever you're giving the medication for, monitor for therapeutic effects, because we don't just give out pills just for the heck of it. We want to make sure that they're helping. So a patient with type 2 diabetes is taking a beta blocker as part of the treatment for hypertension. Which complication is most likely to develop? Hypertension, hyperkalemia, hypoglycemia, or angina? I think we know the answer. C. Beta blockers may mask the signs and symptoms of hypoglycemia. So, implications, what do we give these things for? Rebound hypertension or chest pain may occur if this medication is discontinued abruptly. Instruct the patients to notify their physicians if they become ill and unable to take the medication. Inform patients that they may notice a decrease in tolerance for exercise. Dizziness and fainting may occur with increased activity, and patients should notify their physician if these problems do occur. So if you're taking a medication that is blocking the response of epinephrine and norepinephrine, so kind of keeping your heart rate from getting up there enough, you may have a decreased tolerance for exercise. And if it's keeping your heart rate down too low and you're trying to use those muscles and you're not getting enough blood around to them or to the brain, especially the brain, you're going to have dizziness and fainting. So these are the things you should teach your patient to report to the physician. A weight gain of more than 2 pounds in one day or 5 pounds in a week. Edema of the feet or ankles, shortness of breath, excessive fatigue or weakness, syncope or dizziness.